Thank everybody for coming tonight. This is our first getting to know the real Central City Concern event. And we're really happy that you all turned out on this very nice evening. I understand there's a Blazer game too. So I really appreciate you all being here, but I think we have a very interesting conversation to have tonight. We have three guests with us, but first of all, because I always forget to do this, my name is Ed Blackburn. I'm the Executive Director. I've been with Central City Concern for about 23 years. And so some of my personal story, my experiences at Central City Concern or meet the timeline of what Sam's going to describe to you pretty well. The second thing I always forget to do is the restrooms are right out that door if you need to use the restroom. We have with us tonight Sam Quinones, who is the author of a book called Dreamland, amongst other books. He has been a reporter, including for the Los Angeles Times, in his career. We have our medical director, Solotaroff, who's been with us for about 8 years, 9 years, and has, with her staff and leaders, including Leslie back here, has really carried out a revolution of our healthcare. And it's also very much related to the topic tonight, how we deliver healthcare here. We also have with us Lynda, who is a recovery mentor, has been with us for about 11 years. He's actually a graduate of that very program. It was started in the midst of a response to heroin overdose in 1999, which was skyrocketing. Dr. Gary Oxman was a public health officer and worked with a lot of our clients, alumni, and I'll talk a little bit about that in a moment. We're involved in advocating for more services for people who are heroin addicted to fight this epidemic of heroin overdose. And we were quite successful. So Sam, as I said, was referred for the Los Angeles Times. I first met Sam about 3 years ago when he came out here researching this book. And it took me back in time. And a lot of the things he is describing that he was talking about, how drug dealing developed in this country around heroin and how it coincided with a huge surge in pain medication prescribing in the healthcare world, created this perfect storm of increased heroin addiction. And we were seeing it happening before our eyes, and it put a context for me as I could see how it was happening and why it was happening. At the time, we were into it for a few years by the time I met Sam. So seeing the context, we were experiencing a new surge at the time in heroin overdose. Now I knew how the drugs were being dealt with the effective methods. So with that, I want to turn it over to Sam.
Thanks very much, Ed. How you guys doing? Good? Great. Wonderful to be back in Portland, where I've been several times. I thank the Central City Concern for inviting me up here. It's just good to be in this town. I like it quite a bit. I've been here, I'm not sure, half a dozen times at least. And, amazing to see a sunny day. But, wow, that's great. Let me tell you a little bit about the story that I told in the book, with the help also of Gary Oxman, who we were just talking. I think the first time we chatted was in 2009 when I was working on a story. This story, the story of what happened to Portland, begins really in the early 1980s in Canoga Park, Van Nuys area, where a group of immigrants from one small town that would revolutionize heroin trafficking in America were living. The name of that town is Jalisco, not to be confused with an enormous state of the same name where Guadalajara is located. Jalisco is located in Nayarit, which is one of Mexico's smallest states. It's due south of Arizona, about, I don't know, 10, 12 hours or something like that. Men from this town, Jalisco Nayarit, is not far from mountains where opium poppy grows. And men from this town had learned how to cook it, the opium goo, into black tar heroin. Black tar heroin, you may know, is kind of a semi-processed form of heroin, not the white heroin you see like in the French Connection and stuff like that. Black tar heroin is semi-processed, very cheap to make, does a real number on your veins because it's got a lot of impurities in it. But it's just like heroin in other ways. Men from this town began to deal it in the Canoga Park, Van Nuys, San Fernando Valley area. And they started really by hanging out in parks and kind of cutting off pieces with the addicts would walk up. Then, towards the end of the 80s, 89, 90, 91, a couple of things began to happen. First of all, pagers became widely in use. So you didn't need to stay at the park to see the clients. They could page you and you could go to them. And that's kind of what happened, kind of a rudimentary system, heavily relying on payphones back then. But also, this was also the time when gangs in Los Angeles were taxing drug dealers on the street. You had to pay a rent to sell in certain gangs areas. But that wasn't the case if you were in a car. You could drive around, and so you could avoid the taxation. So these guys moved to cars. And they began a delivery service. It was quite a bit like pizza. You would call, and they would dispatch, and the guy would come with whatever you wanted. At the same time, this system was becoming really popular back in this little town. These little towns in Mexico are intensely driven by kind of social competition. There's a lot of poverty and a lot of classism. People in this town began to see this at, particularly folks who were landless, who were kind of in dead-end jobs, bakers, butchers, sugarcane farms, a lot of sugarcane in this area, coffee as well. They began to see this as a system through which they could get some economic progress far quicker than they ever would being a coffee farmer, or even, frankly, coming here to work, say, landscaping or restaurant work or drywall, whatever it is they were going to find. One of the things that struck me, just as an aside, when I traveled around Mexico, my first two books were about Mexico, Mexican immigration. Everywhere you go in Mexico, the villages skyline, the skyline to all immigrant villages includes rebar. Rebar is sticking up out of the houses. The reason for that is people use their dollars to build houses, but they don't have enough accumulated to build a house all at once. So they build a few rooms, they add on to it over a period of 15 years, say. They put rebar after the first floor because it's a promise of, like, when I have enough money, I'm going to build the second floor. All across Mexico, you see rebar. All across Mexico. It's just part of the skyline, right? Except, one of the first things I noticed when I went to Jalisco Nayarit was there is no rebar in the whole town. I was like, where's the rebar? Well, heroin provides that economic sustenance to be able to build a house all at once, and also really nice architectural lines, none of this kind of rudimentary stuff like in immigrant villages. People would put in wrought iron. There was automatic garage door openers, became quite the rage. One guy told me when the first heroin trafficker built a house with an automatic garage door opener in his village, the old people stood in front of the house, just watched the thing go up and down. They'd never seen that before. It's just this amazing thing. They develop a system that is greatly enhanced later by cell phones, but the key thing to remember as it affects Portland is that this system was not a cartel. It's a system that it's like a mom and pop franchise system. Anybody could do it, anybody could work in it. There was no violence, they all knew each other, so they would compete in Van Nuys, Canoga Park. They all competed, none of them killed each other, they were all just kind of competing for business. As time went on, saturation point was reached in Canoga Park, Van Nuys. Too many cells were around. There's a lot of cops were beginning to arrest people. Some of the more adventurous of these folks began to leave the San Fernando Valley. The first places, I think, were San Diego, Pomona, Ontario, which is like east of LA. But Portland was about the third place that they went. And they come here in about 1990, 1991. And I know this through talking with addicts who were around at the time. One fella that I spoke with has no legs. He had them amputated years ago. And for him, finding heroin, he'd been a junkie all his life, most of his life, finding heroin was a daily torture because he had to walk around on his prosthetics looking all around in here for the guys who were posting up selling their heroin. All of a sudden, these guys will deliver. What's more, they'll deliver the same amount. And you can kind of nickel and dime them, you say. Yeah, they'll show up and I don't have enough. Okay, that's enough. Give me that money. I'm fine with that. And it became a system that was very customer service oriented. People would be, you would want to make sure that you got there quickly and got the addict as though quickly, this kind of thing. This came in about 1990, 91. The cops who were working narcotics back then said they remember it very distinctly. It revolutionized heroin dealing, which before was done out of some seedy motel or bar or down here. It was a very dicey thing. People didn't like doing it. All of a sudden, the Jalisco boys show up, and more crews show up, and pretty soon, it's a phone call away. You make a phone call, they deliver. It's very easy. From that point on, because it was so easy, because it was so cheap, and because these guys controlled their supply, so they made it and then took it here. It didn't get diluted the way heroin usually does when one guy buys it, sells it to somebody else, dilutes it, sells it to somebody else, and by the time it reaches the street, it's changed hands 4 or 5 times, and it's about 12 to 15%. DEA says it's like usually 12 to 20% potency. These guys sell 60 to 80% potency heroin all the time, every time, because they didn't want to lose their customers. They were in competition with each other, and they knew that these addicts had several numbers for each crew, and so this is what begins to happen in Portland. And I think Gary's investigation that he did in 1999, when it was perceived that there was a real epidemic of heroin overdose, fatal heroin overdoses, they begin to chart that back, step that back year and year for several years, and they realized that heroin overdoses really have been rising for 10 years, almost 10 years by that point, almost exactly from the moment when these guys arrived in Portland. And they're still here, and many of them are still here. So this system revolutionized heroin trafficking in this area by making heroin cheaper, more convenient to get, which is a huge thing, for more reliable. For addicts really need reliability. They need to know that when they can call and they can always have it, and less violent. So there was nothing to arouse public ire, like shootings and killings and what have you. All of this plays out very clearly in Portland, Oregon, beginning in about 1991, and continues to this day. Now, what happens in 1999 is the public health department goes into kind of a advertising mode, trying to get people to not ditch their overdosing friends, and here's how to save your friend if he's overdosing. There's a public relations campaign, a publicity campaign to teach that, and overdose deaths begin to drop, not heroin use, but overdose deaths begin to drop until 2004, roughly about that period comes along, and you have the arrival of pills and a real serious overprescribing of pills. OxyContin comes along, and that again sees the increase. And I think that's what people in this agency, talking with Ed back when I visited, people remembered how all of a sudden there was this switch in the early 90s from a lot of other drugs to heroin. There was all of a sudden a whole increase in addiction. And they were seeing that in the patients who were seeing daily, and a whole lot of stress on the system that wasn't prepared for all that. And all of that takes place, I think, largely, I'm not sure if 100% necessarily, but largely due to men from this one tiny town in Nayarit, Mexico. And that is the story that I try to tell. This system that pushes them to compete, and therefore pushes them to always search for new virgin territory, push them across the country. After Portland, Denver, Salt Lake, Boise, Albuquerque, they went east and now are in, they're across the Mississippi River, and they're now in 17 states, plus another 8 states on and off, depending, across the country, and all from a town or a county, let's say, of about 40,000 plus people. And that's part of that's my story that I tell in my book about how, and these guys, the importance to these guys too is when they go across the country, when they go across east, they collide with the expanding promotion of pills, and they begin to realize that the pill market is, particularly some of them, begin to realize that the pill market will soon be the heroin market. So you follow the pills, you will have eventually a very nice heroin market. It's a great day to be a heroin dealer in America, basically, is one of the things I say in the book, because these guys figured that out. These guys figured that out first, and because of the system allowed them to kind of see it in a sense.
So Sam, it coincided with the huge increase in prescribing for pain.
Exactly.
You want to talk about that just a little bit?
Sure.
The philosophy in the healthcare will change in the 90s. Right?
Exactly. There's a revolution in healthcare that takes place in U.S. medicine, stating that we are a country in pain, and what's more, that we now know that opioid, whatever you want to call them, opiate painkillers are virtually non-addictive, and therefore can be used in large amounts to treat this pain. They're virtually non-addictive when used for pain. And this is something that, this is what starts our opiate problem in America today. It's not started by the underworld or a drug gang. They come later to this. They may be already operating, but their big market is created by huge amounts of rising sea level of supply of pills all across the country. Promoted first by a group of pain specialists who believed that this was the right thing to do. Someone could call into question their sincerity. I don't know them personally, so I'm not going to comment on whether or not how sincere they were, but what their effect was to change lots of minds of doctors all across the country. That's why we have now heroin addiction in Alabama and Vermont and Idaho and Tennessee, states that never had any of this, or Ohio really didn't, for that matter. But this transformation of U.S. medicine's approach to pain and how to deal with it, and the willingness to use these pills was just a revolution. You know, in the 70s and 80s, these pills were almost not used at all. There was what they call an opiophobia, the fear that no matter who you use them on will become addicted, even if it was a person who was terminal, 3 months more to live, you know. So the pendulum began to swing. And now we are at a point where the United States uses 98% of all hydrocodone in the world, which is an opiate derivative, a synthesized opiate painkiller. And that's what you find in Vicodin. 98% of all hydrocodone in the world is used right here in the United States. 83%, I think the figure was, of all oxycodone, which is what you find in OxyContin, is used here in America. And this is a radical change, a revolutionary change from the 70s and 80s, when people didn't even dare treat people with cancer with these pills. But these pills are very similar molecularly to heroin. Doctors don't tell you that. They need to tell people when they prescribe these a little bit more about what they're giving them. And so when people get addicted to these pills, as many do, even though they say they're virtually non-addictive when used for pain, it just has not been shown to be the truth at all. Many people get addicted, and then for a variety of reasons will transition to heroin. One would be the doctor is alarmed, sees the addiction, and cuts the person off. That's one. Number two, the pills are just not easy enough to get. Or number three, the high is no longer quite what they're looking for, and they want to go to another thing, and so heroin. But whatever the case, the cost is usually the factor. The pills on the street cost $1 a milligram, and most people are doing 150 to 300 milligrams a day. Black tar here in Portland is, I think, I actually don't know what it is right now, but it's been on the order of about $10 to $15 per dose per day. So you're talking about 3 or 4 of those So you're talking 50, 60 bucks a day as compared to 300. Well, you can see that the difference is dramatic, you know, and that's also been taking place at the same time. The dropping of heroin's price, largely because it comes now, we almost don't get any heroin anymore from Asia. The idea that you can say what you want about the Afghanistan war, but there's no heroin coming from Afghanistan. It's all, okay, that's 7,500 miles away. We have heroin grown like 3 hours from here by plane, and that's where it's coming from.
Thanks, Sam. We'll give you a chance to ask Sam questions later. I want to introduce Rachel, who's our Chief Medical Officer at Central City Concern. And she is running a very sophisticated, as medical director, her aspect of the job is very sophisticated primary care. And we're very appreciative of her. She's introducing new concepts in her staff and how we deal with this issue, as well as some others. And so I want to let her go.
Introducing some new things and learning a lot from our peers at Central City. This is a little less sexy to start out with, but I wanted to give you all a sense of how bad is this problem in Oregon compared to the rest of the nation. So, sorry, this part is a little dorky, but just to get you through it. This is data that looks at the idea of non-medical use of pain relievers, which means taking these pain pills that Sam was talking about for reasons other than for a medical purpose for pain, using them recreationally. And these are data that are collected nationally by survey. And you can see, this is looking at the years 2012 to 2013, but red is the highest percentage of patients, and there's Oregon, which is red. So down at the bottom here, I wanted to give you some other data that in 2011, because there are a lot of other red states here, so how bad is Oregon compared to the other states? In 2011, Oregon ranked #1 in the nation in terms of the percentage of people who said they'd use prescription painkillers for non-medical use. It was 6.4% of all people over the age of 12. It was about 18% of people between the ages of 18 and 25. Staggering numbers.
Wow.
It's fascinating. So lowest, Iowa. Midwesterners, they made me really happy. And then that trend really continues. If you look here, the data down here, that Oregon, in this map, can't tell because they're all red, but is second in the United States. Still, the numbers have dropped a bit, but still about 5.8% of all people over the age of 12. So we're in, the problem here in Oregon around non-medical use of opioids is it's among the worst in the country. So what are the consequences of that? Well, this is our rise in opioid-related deaths in Oregon in the last 10 years, and this is from folks from here to shop at the Multnomah County Health Department and the Oregon Department of Health. But this is, sorry if it's hard to see, but this is just number of opioid deaths, and that's by pills. This isn't heroin. I'll get to that in a second. And it's a 5-fold increase in the past 10, 11 years or so. It's tapered off a little bit in the last couple of years, but it's quite dramatic. So the stuff Sam is talking about in terms of the prescribing we're seeing in terms of fatalities. They're more numerous now than motor vehicle accidents. And it's worth noting what some of the risk factors are for people who die of opioid overdose. Men more than women, men particularly in the ages of 35 to 54. People who are prescribed, this is common sense, but people who are prescribed high doses of prescription opiates, people of low income, people of rural and not urban residents, and people with a history of mental illness and people with a history of substance use. So as Sam also talked about, there's a point with prescription opiate use where it becomes too expensive, where it doesn't get your receptors as saturated as it did before, and people convert to heroin. So totally coincident with this, we saw a rise in heroin deaths as well. So the top line is a rise of sort of a little bit of fluctuation. I'll give you the percentages in a second. The top line is Oregon heroin deaths, which peaked at 147 in 2012. And then the rise of heroin-related deaths in Multnomah County, which were at 80 in 2012. So this is about a 42% increase with a much more dramatic increase just as we moved into the teens on the order of 59%. Just so you know, in 2013, the data are on the slide, the numbers of heroin deaths did go down. They went down from 147 to 111 in Oregon, and in Multnomah County, they dropped down to 65. So we've got reasons to be optimistic. We're making progress, but the situation's pretty severe. So I wanted to talk a little bit sort of about our approach at Central City, but sort of from my own perception of how I've come at this as really as a primary care provider. And again, it's with a lot of patient teaching from my patients here and my colleagues. So I don't want to espouse that these are just my views alone. But I want to start out by saying that this is a very complex problem, as we pointed out, and there are many, many paths to success. There's many different approaches for how to treat opiate addiction. And no one is right, no one path is right, and frankly, no one path is more right than the other path. I think it's so important that we hold that in our minds, that this is a big tent, and there's plenty of room for everybody underneath that tent. So given that, I want to focus on, pointer down, just a couple of key elements that I think are under that tent that Sam, who covered, whose book was so expansive and fascinating, but I didn't see as much, so I wanted to give you my perspective on. So the first really is the role of the physician and of the primary care team, not the pill mill physicians that you read about or the ones who are sort of hucksters for drug companies, but just your ordinary everyday primary care physician. And I think it's important that we recognize that we're culpable. We're not the sole perpetrators of this epidemic, but we're part of it. We hold responsibility both for its genesis and for its solution. And the way I think about it is, look, it took us a pretty quick 10 years to get ourselves into this mess. It's going to take a generation or more to get ourselves out. So we better be patient and learn as much as we can and move forward methodically. And I think what also complicates this is not just our own culpability, but I'm of the opinion that there's a collective sense of shame in the medical profession around what's happened here. And some of the silence that Sam talks about in his book, I think part of it is that sense of shame of how we as prescribers with prescription pads contributed to this. Well, so what can we do? I think the most important thing to do, starting number one, is primary care providers need to understand addiction. It is as prevalent in this country as diabetes, 25 million people. And a study in the New England Journal said that doctors provide evidence-based care for addiction 10% of the time. That would be unacceptable in any other illness, but that's the state of the state with addiction. So get trained, take some classes, read some books. There's information out there. And then get to know your addiction providers in town. In Central City, that's a little bit easier because they're across the street and they're down the hall, but if you're out in practice in any other place, go talk to somebody who's running an inpatient detox facility or an outpatient alcohol and drug rehab program. Go to the methadone clinic and find out who's working there and what really happens there. And talk with your patients about their recovery or their use and understand the processes and terminology, sponsors, clean time, home groups. I learned a lot of that here. It's been enormously helpful. Go to an open AA meeting or an open NA meeting so you can really understand. There are great behavioral treatments for addiction. There are also great medications for addiction. There's one called buprenorphine, which you can get a license for and you can prescribe in your own practice. And it works wonderfully in concert with behavioral and community supports around recovery. And if you have patients who use pain medications, low doses or high doses, give them a prescription for something called naloxone, which in the horrific event that they overdose is an antidote to that overdose. Train their loved one on how to use it. Just like if you had a patient who had a bee sting allergy, you train their loved one on how to use an EpiPen, train a loved one on how to use naloxone. And then around chronic pain, just slow down and be patient. And it's not a black box. We have things that we can do for chronic pain. It's not that you're lost without just writing a prescription. And we know what works. We know there's evidence physical therapy works, yoga works, gentle exercise that reduces people's fear of pain with movement, reduces their alienation from their bodies, which does happen with chronic pain. You can use cognitive behavior give people mental coping skills, as well as sort of an acceptance and a readiness for other kinds of treatment. There's excellent evidence for acupuncture for chronic pain. And you can use opioids for pain. Use them judiciously though, and use them minimizing hooks, minimizing things that make people think about their next dose, or minimize things that that would trigger people. Ask your patients, what's important to you? We use this term a lot here, that word occupational therapists, of meaningful occupation. How do you want to spend your time? What do you want to be? And work with them toward those goals. It's avoiding, as one of my colleagues says, avoiding that soft bigotry of low expectations, where if you're not using your meds, that's good enough for me. Well, it's not good enough. And you need to take time with interdisciplinary care to talk with other team members within and without your clinic. So what does this take? Well, it takes time. It takes a lot of time. And it takes patience, and it takes the ability to compromise. It also takes a lot of listening. Doctors aren't good at listening. You really got to listen 99% of, well, maybe 95% of the time, because that's when you're going to understand the answers to those questions, what people really want and what's getting in their way. And to be honest, we don't really have a choice at this point. So the other thing I did want to point out that I also reflect a lot on in reading Sam's book and just in learning about addiction here and working with my patients is the role of environment and context. Because morphine is an amazing molecule, and it's often a hidden molecule, but it isn't a virus. It doesn't land in just any unsuspecting host. There's rich evidence about what sort of environment addiction flourishes in. It's often in settings where there's a lot of trauma, particularly early childhood trauma. And I've learned this from my behavioral health colleagues, understanding the role of insecure attachments in childhood, where parents aren't dependable or responsive or attentive, but instead other people, adults, become a source of terror or neglect, or at best even ambivalence. So if you don't have that kind of dependability in the outside world, you don't have that ability to soothe yourself, to remedy yourself, to bring yourself to what psychologists call attunement, or a sense of harmony in the world. And so if you don't have those natural sources of self-soothing, you look for other ways to relieve pain. And that's often what substances do. Is that a healthy adaptation? No. Is it a normal and understandable adaptation? Yeah, I think so. And so what I always try to think of myself when I'm sitting there as a primary care provider with someone on the first meeting is not to ask them, why the addiction, but ask them why the pain. Not what's wrong with you, but what happened for you. I think that helps to get at the roots of why people are using and what their paths are to recovery. And if you think about those risk factors for opioid overdose that I talked about a moment ago, poverty, isolation, mental illness, they beg questions of solutions that aren't just about better prescribing practices or better prosecution or even more addictions treatment, all of which are important, but they speak to me about building power in our communities, of supporting healthy families, of supporting social connectedness and economic opportunity, reducing poverty and marginalization. And as one writer put it, perhaps the opposite of addiction is not sobriety, perhaps it's human connection. Over to Lynda.
Thanks, Rachel. Again, there'll be chances to talk to Rachel. So, talking about 1993, I was the director of the Hooper Detox Center. Hooper had by then had a long history of helping people with severe alcoholism, who were mostly on the streets, but lived in a lot of the single-room occupancy hotels downtown as well. But in 1993, we saw something there starting that just took us completely by surprise. That year, we saw a surge in people seeking detoxification services from the Hooper Center. Went from about 10% of the people that came there to about 30% one year. By 1994, it was up to 40%. I believe by about 1995, it was up to 50% of the people that we were serving at the Hooper Center were addicted to heroin. And there was a lot of confusion about what was going on. I got a better idea about what was going on now, but by 1999, 98, 99, we saw the surge in overdose happening. I think that bottom line on heroin had showed about 33 in 2000. 2002 was actually about 130 or 40 in 1998. And I remember Richard Harris, who was the executive director at the time this year, coming to me with this federal grant. And he stuck it in front of my face and he says, I think we can organize consumers with federal grant money. I was very skeptical, but I read it and looked like we could. So we applied and we got this big grant I was a project director for. We organized a thing called the Recovery Association Project. And we actually recruited some people, or very few people in heroin addiction at the time in recovery. And we got some of them together, and they attracted more people. And we explained this vision to them that we're going to create an organization. Rachel says communities of power, empowering communities. So we thought part of the answer to this was getting people empowered who went through the experience of heroin addiction to advocate for more services and more new approaches to the heroin addiction problem. And they ended up working a lot with Gary Oxman on all kinds of things that were done in the community around educating people, around getting the police to put out the message that if you reported an overdose, we're not going to come and investigate you and arrest you. There was a lot of things that were done to see that go down. But one of the main things they came up with, and this came from a training we were doing where people in recovery from addictions were talking about what we should do. And one person described, he says, what we need is this. I went through Hooper Detox several times. Before the day was out, I was back with my old crowd using heroin because I didn't know where to go. I didn't know what to do. I had no food, I had no safety, I had no relationships. So he said, what we need is someone who's achieved some heroin recovery to come into the Hooper Center, meet somebody, take them out of that facility, get them involved in treatment, take them to treatment. Don't just give them a referral slip, take them. Sit there with them while they get enrolled, get them into housing that day, surround them with people in recovery, because in the end it's about these relationships that are going to help these people, and stick with them until they got a community around them in recovery. And that became the basis of what we call a recovery mentor program. And we have recovery mentors and peers now working throughout the organization who come off of that model. One of the early graduates of that program, Lynda Williams, and well, we have a couple of others here too. And but Lynda is now a recovery mentor, who's worked with us for about 11 years, and so she's going to share her experiences.
Thank you. The human connection, absolutely right. The human connection and that story was very impactful. And what genius to have come up and have a property of people to come together and say, that's right, it's one addict helping another. And what has happened in that, in gathering, it allowed, certainly for me, it is, if you will, gave me permission to recover, having that safe place to be, having the only thing, in the people in the recovery mentor program need to worry about is just that. It's having a safe place to be. It's figuring out, you don't have to worry about putting a roof over your head. You've got treatment. You've got a recovering therapeutic community around you, people, like-minded people trying to do the same thing that you are. The requirements of the recovery mentor program: go to a meeting every day, find a sponsor, get a home group, be of service, get a support group around you of the same sex, really important piece. And in doing that, what it allows you to do is create a new lifestyle for yourself. What was always wrong with the whole thing is that people could go to treatment, but then how are you supposed to you get out of treatment and it's like, what, you're going to get a job after all these years of your drug addiction? You're going to get a job, you're going to somehow figure out how to take your family back, reunite with your family, take care of these things. And what the Recovery Mentor Program allows you to do is it changes that whole impact. It changes that it puts recovery first. And what we do now, and it has evolved, Now people, in addition to finishing treatment, they're involved in the community, volunteer
Corps.
Thank you. Volunteer Corps. This allows people to get re-engaged in what it's like to show up to work, what it's like to pack a lunch, what it's like to get back to the community, set an alarm, be somewhere, be part of that. A lot of people that get involved with that, complete that, are also able, after they graduate, to go into Clean and Safe. Again, allowing them employment opportunities and creating. A lot of our people, after they completed treatment, they've community volunteer corps, they will then go to our employee recovery program, which is upstairs. It's in the same building. It allows them to stay connected to the community. They work with the case manager. They're then working with the Employment Access Center, all services. So they're figuring out how to get a resume put together, work with an employment specialist. They've got somebody upstairs. They're in safe housing, and they continue this transition from that one place of complete homelessness into a little bit of hope in a community that's impacting them and doing the like-mindedness, getting a little more excited about recovery, to succeeding in the community volunteer corps, to going upstairs to the employment program, and getting out in the community. And the success rate is phenomenal. Our program alone is typically about 70%. Those that go upstairs and graduate the employment program, it's about 85%. Phenomenal numbers in the impact that this has, you know. And I would really like to just really add with those numbers that were presented here with that pain medication. A lot of our people are a lot younger. Opiate addicts are coming on board here, and I know it began with the pain medications, and it does. It segues into the heroin addiction because of the cost. That's absolutely right. It starts out as with the pain medication. So there's a large, successful young population that's doing very well in the recovery community with this model, because of this model that's being presented, that there's hope. There's not this endless drudgery like when I came. So, you know, it's been, it's a phenomenal model that has just grown and evolved and is touching, like I said, with the employment piece and the Employment Access Center, the community volunteer corps, giving back. Yeah, it's an amazing program. So, yeah.
So for those of you who don't know, we have this robust healthcare approach for specializing in homeless people and other people with very serious chronic conditions, including addiction. But we also own or operate about 1,600 units of housing. For much of that housing, it's supportive of people making this kind of lifestyle change. But in addition to that, we do employment services. Every year for the past few years, we've placed about 500 formerly homeless people in jobs, most of those people in recovery. We work with about 300 employers around the region. So we built this context that Rachel's talking about as well, in the environment where people are in. We're actually offering people a new environment. I think that's why it succeeds. And I think we'll see the same kind of enhancements on the use of buprenorphine or Suboxone for people who have not been able to make the abstinence route. There are those people too. So the question is, what is good for the patient? It's not what we think should be good for them. So we have these different routes. And if they can choose those freely, more likely to be successful, we think. Now that choice is very limited by stark realities of their suffering. But we need to offer people different paths to save themselves. A couple of just facts for startling to me. The needle exchange programs in Multnomah County did a survey about a year ago, surveying their people on how they got started with heroin addiction. 43% said it started with prescription pain pills. That's disastrous. That number did not exist 20 years ago. So when we have 1,000 people receiving a year with heroin addiction at Central City Concern, and 400 of them started with pain, that's 400 people we wouldn't have been seeing a few years ago. So it's complicated and it's very dangerous. And so we need to use all of our ability and all of our thinking now to try to address it successfully, working together. The other fact that startled me today, when I got some numbers from the Hooper Center going back to 2009. In 2009, we had zero people at the Hooper Center under the age of 17 that year. We've had a few in the past. Today, we have 90. Now, this past year, we had 90 under 17. All heroin. 64% of our heroin addicts are under the age of 31. So this has been a population that to some degree has been created in the last 10 to 15 years. I think Rachel's right, we're going to have a struggle getting out of it, but there is hope. There is hope. So, with that, I would like to open it up to any questions you might have.
I do have a couple questions. You mentioned the population under the age of 17, so that's a very large number. What do they attribute that to? Because normally, most physicians are not giving teenagers opiate prescriptions.
Well, they're buying it on the street.
Okay.
Or they get it from their parents'
Yeah,
medicine.
yeah.
Okay.
Medicine cabinets.
And then also, Dr. Solotaroff, how much time do you get with each of your patients?
Well, so, I mean, appointments are scheduled at 20 minutes long. Some are shorter and some are longer. And sometimes I have to realize that maybe what's on mine, I think doctors think appointments are short because their agenda is so huge. If you actually put your agenda aside and talk about what is important to that person, you have plenty of time. I think, and then in time, you build trust and you build engagement, and then they'll let me talk about diabetes and hypertension. So I think yes, it's busy, and I won't say it's not, but when you can sort of expand and contract depending on the complexity, but again, I think it's important to think about time is time seems short if it's all about what you're trying to get out of it. The time dilates if it's somebody else's agenda.
Because I can imagine that a lot of physicians are prone to giving prescription pain medication because it's like, oh, this patient comes in, they're always calling my office, they're always like complaining, just get them off my back.
Yes, I mean, that's correct. I mean, I'm no doctor, but I've talked to a number of doctors who said that, that it just puts an end to the conversation. You pull out the pad and there you go. And the other thing though is, getting back to what you earlier said, why are so many kids getting it? Because we give huge amounts of pills for every surgery. I didn't realize this at the time, what was happening to me, but I had a appendix out about 5-6 years ago. And I took 2 Vicodin they gave me in the hospital. And then they gave me this big bottle of Vicodin. I didn't know what it was. I didn't know what hydrocodone was, and they said if they said similar to heroin on the thing, I'd have been, that's what they should have said. Right. Do not mess with this. But what's the message? The message is really, we're giving you 60, you can take it when you get home. Yeah. It's like, it's non-addictive, don't worry. And kids are getting into it because there's so many of these pills being prescribed, 60 Vicodin, 90 OxyContin. You get this kind of buildup. There's this like rising sea level of pills all across the country, and that's another part of this story. That's just people getting into the pills in their own homes.
And hearing all of you speak, I mean, I've been in practice with cancer patients for 20 years, and I consider myself pretty judicious about prescription. But hearing you guys all speak, it makes me want to run and tell everybody turn off the spigot, because it sounds like there's just lack of awareness.
But be cautious about the pendulum swinging the other way for 2 reasons. One is that, that downtick in opioid overdoses that isn't on the graph but is there. The next year there is an uptick in, the rate of decline is slower for heroin overdoses. So be careful. We've seen reverberations in this community when we say, oh, sorry, we made a big mistake with opiates, you're done. Well, that's, you know what, you have your culpability in that. And so we can't, turning off the spigot has unintended repercussions. I think the other thing too is, do we have really terrific evidence for the use of opioids for chronic non-malignant pain? No. But I still am of the opinion, I'll say this, that absence of evidence is not evidence of absence. And I do think there are situations where chronic pain in a full pain management program where opioids can play a part. So I would be wary both from a unintended consequences point of view and in terms of a good practice point of view from swinging the pendulum too far the other direction.
In 23 years, I've seen the pendulum swing.
Mm-hmm.
When it gets wild, bad things happen. Often under the best intentions.
And I'm just curious about a figure you said 90 teenagers basically at Hooper in 2014. Do you have a breakdown of female to male?
I don't with me, but I think a lot of them are female.
Anecdotally, when I visit, it looks that way.
Yeah, I think we're seeing more young women addicted to opiates than we used to see. It used to be, back in the day, it was a 40-year-old heroin addict that used China White. Sometimes they'd never been arrested, and all of a sudden their life deteriorated and found themselves toxic. Others were in bad shape in their 30s, but this is a different population. That was when we had 5 to 10% of our admits were people addicted to heroin. It's much more democratic now.
Well, this is in the media, we always hear about meth.
In the media,
It seems meth is taking over Portland.
Can you restate
I
the
don't-
question?
I mean,
Methamphetamine,
the story of
it seems like it's
methamphetamine
always
is
in the
equally
papers.
strange. I'm not sure if I know a lot about methamphetamine in the Portland area, but
a little bit about the silence that you
sure. Okay, sure. I think one of the things that we've seen here with this epidemic is how quiet it is. I began my career as a crime reporter, and I was in the town of Stockton, California, which is, if you know anything about Stockton, I love Stockton, but it's an intensely violent town. And particularly then, it was the middle of the crack years, and it was accompanied by drive-by shootings, carjackings, Bloods and Crips now were in Stockton, and it was very public. I mean, carjacking was basically invented during the crack years, and drive-by shootings were resurrected from Prohibition. The first time really they've been used widely since Prohibition was during the crack years, right? So it was all this public violence, arousing public outrage, pushing public officials to do something, devote budgets, et cetera, that kind of thing. None of that has happened during this thing that we're talking about now. It's all very quiet, and there's several reasons for why that is. First of all, it's coming out of doctors' offices. You know, people generally think, well, the pills have doctors' marking, pharmaceutical markings on them, so they must be okay. So there's not a lot of, it's not like a piece of rock cocaine, which is cocaine cooked with baking soda and water, and it just becomes hard, and you can, it's something looks very comfortable to us. But more than that probably is the fact that the people, there's the violence, there's these other factors, but probably most important is that the folks whose kids are dying are mortified, are ashamed. They grew up in the 70s. Most of the kids who are dying, their parents grew up in the 70s when, as I did, when heroin was like this, dingy, awful, scuzzy back alley thing you never wanted. You smoke weed all you want, but heroin is just like the last. And people are mortified that this has happened, that their beautiful children are now dying on McDonald's bathroom toilets. And on top of that, most likely if they're dying, they've already been through 2, 3, 4 years of horrible addiction with the kid. And it doesn't just addict the kid, it addicts the whole family is involved in this addiction. The younger siblings are resentful, or the other siblings are resentful because all the parents' time and money is spent on trying to cure this one kid. Huge mortgages, second mortgages, college savings erased, wiped out. You learn what it's like to stand in line to get into jail, to visit your child. You get very expensive collect phone calls from jail. There's this whole long process that accompanies addiction that then ends with the death. And the people whose loved ones have died are, for a variety of reasons, worn out, withered, ashamed, stigmatized, whatever, and they just don't want to tell the story that would, their stories are particularly potent in igniting public ire, the way a mother whose daughter was killed while she was in the bathtub with a bullet that went, a straight drive-by shooting bullet, which is what a story I wrote before, when I was in Stockton. There aren't those stories. People are really reluctant to tell the story. And that is a problem. And that's why it's spread, if you ask me. That's a big reason why it's spread. The quiet, the silence that accompanies this is a big part of why we have it all over the country now.
My question's for anyone. What are you seeing? Are you seeing measurable and increasingly more common Adderall and Vyvanse addictions?
I can't speak. I'm looking at my colleague. It's like the repository of all things numeric. I don't know. I mean, what I tend to see more is around people who are abusing amphetamines and not methamphetamines, but prescription amphetamines. It's a polysubstance thing. They're using maybe heroin and benzodiazepines like Valium, but then they're also buying Adderall on the street. I see a lot in the context of polysubstance use. But again, I will admit I see a fairly segmented population. I don't take care of college kids, for instance. We may see more of that. And Leslie, I don't know if you can know off the top of your head any rise in stimulant dependence.
We don't have, it hasn't been a noticeable pattern in the past few years. I mean, really, what we see in our population is a lot of alcohol and a lot of opiate abuse. Sort of the prevalence of CNS, like central nervous system stimulants, is significantly lower.
Are you thinking
Thank
of
you.
something, Dan?
No. Except that, as I hear you talk, Adderall is more common among families with resources.
Mm-hmm.
It seems like to me, and perhaps that's
something we should look into.
all right.
Yeah, Oregon's unique in a lot of ways, and when I think of Oregon, I kind of think of Portlandia with cyclists, environmentalists. So I'm kind of shocked with the drug. I don't associate drug use with Oregon. So what do you guys have a sense as to what is it about Oregon that's unique that causes the drug abuse to be so high that we're leading the nation?
Well, I mean, I don't, the drug problems are awful bad in a lot of other places in the country. That's the truth. I think even in places like Sam was talking about, they didn't have these problems 30, 40 years ago. In the South, in the Midwest, and some of the West Belt, where you had this huge influx of pill dispensing around Oxycontin and this type of thing. Left devastated towns even more devastated. I don't know. I mean, we got some numbers on prescribing opiates are much higher than the average. And it may be that the pain management theory was more embraced here. And this was a whole change in the way the healthcare industry saw managing pain.
So we were more progressive?
I think more progressive and more on it. And sometimes that backfires on you if you're a leader. But Sam relates this chain of thought that really occurred in the late 80s and 90s. And what's fascinating to me, because I've seen much smaller, less dramatic examples of this, and you could talk a little bit about this, there was a so-called landmark study that was published in the Harvard Medical Review.
New England Journal.
New England Journal that said less than 1% of the people who are prescribed these substances become addicted. And that quote that pervaded all kinds of scientific journals, conference presentations, salespeople had this thing that's and selling these drugs. You want to talk about what it really was?
Yeah, it was. It's one of the weirdest stories. This story is filled with weird stuff. I have to say, as a journalist, I'm really awed by all the weird stuff I encountered. But one of them was in 1980, a doctor named Dr. Herschel Jick at Boston University, who still runs, I interviewed this guy, a database of hospital records. At the time, the database was 300,000 hospital records. And he, who was getting used to at that point, had one of those kind of primitive computers and stuff like that. He was getting used to asking questions of his data, right? And what they'd say about it. And so one day I think he said, he told me, I read in the newspaper something related to narcotics in hospitals and addiction or something like that, and he couldn't remember, but I asked the guy to run the data and see, okay, how many people who get opiate painkillers while in hospital get addicted. Of the 300,000, this was all a database prior to 1980, or 79 really, 11,000 hospital records showed the patient was given that, 4 got addicted. So he thought this was an interesting piece of information. He didn't presume that it was anything more than, hey, just an interesting point of note, you know. And he writes it up on his yellow pad, gives it to his secretary, secretary types it up, sends it in the New England Journal of Medicine, which publishes it on January 12, 1980, in the letters to the editor section, page 120 something, with the headline, "Addiction rare in patients given narcotics." I should know exactly what there was. Addiction rare was the thing. So, and he promptly forgot about it. He says, that was like the least interesting thing I had ever done. I just sent it off and I forgot about the whole thing. But it was then rescued from the oblivion in which he intended it by these pain specialists, in particular, a guy by the name of Russell Portnoy. Dr. Portnoy is like a leading figure of these pain specialists, who footnotes it in a very influential paper in 1986 that he and another doctor wrote, using a very, very small, anyway, it's a long story, but basically what ends up happening, this letter to the editor, which is 101 words, is then, because there's so little evidence of any kind saying that these are non-addictive or virtually non-addictive or whatever the term you want to use, when used for pain, they fasten on anything they can find. And this is one of those things. And they begin to talk about it at conferences, continuing medical education seminars. They make speeches, him and several others who are important in this story, but mainly he's a big part of this. And after a while, it becomes gospel truth that these are virtually non-addictive when used for pain, that less than 1% of all patients treated for pain with these pills get addicted. There's only one place, I believe, in all the medical literature that says that, and that's that one letter. The doctor himself is oblivious to this. Dr. Jick he's going around doing studies with his data and expanding his data. It's now 6 million records, hospital records. He's very proud of that. And he does all kinds of studies about the hospitalization and drug use while in hospital, drug effects while in hospital. Anyway, he is really, I think, oblivious for many years. He finally gets subpoenaed by a federal grand jury, which is investigating a case against Purdue Pharma, which makes OxyContin. And he's like, what's this? You know, why? I'm not going, screw you. And they send a sheriff to tell him he's going to go. And he finally has to go. But what has happened in the interim is people begin using this letter as proof, and it becomes like a scientific game of telephone. Starts out with it's nothing, and it becomes a landmark report. A report. First it becomes a report, then it becomes a landmark report, then it becomes a landmark study. Time magazine called it a landmark study in an article in 2001 that shows that all we knew about addiction and pain pills is completely old hat, and it becomes Porter and Jick. Everyone tosses it around as if, well, you know what Porter and Jick says. You know, Porter and Jick says this. Oh, well, of course I've read Porter and Jick. Of course, you know. The other thing is, no one really bothers to read it. No one bothered because for a long time, obviously, there was no internet. So you couldn't go look, it was very difficult to look up. But even after the internet, New England Journal of Medicine didn't put online all its records until 2010 or 12, I can't remember. But for many years, you could only go back to 1993 or 6 or something like that. And so in order to actually go and see and check what this was and that what, you had to go to a library and find the edition from 1980, and no doctor was going to do that. So they just take the word of the people who say it's a landmark study that changes what we know about addiction and chemicals. That was one of the most mind-blowing stories ever. I mean, I couldn't even believe it, really, you know, until I started talking with doctors, and no, it was gospel. I know a nurse who gave these seminars all the time. We quoted that all the time. Yeah, so.
Richard.
I can remember the day that, like, we got notification from the DEA that methadone is being removed from the restricted prescription. And I don't know what I said it to you, but I said, we are in deep shit. Because just as soon as this is prescribable by any physician, it's going to be in wide use all over the place. In fact, Gary, I think I remember saying something to you about it at the time. That we're going to start seeing this flood of people that we're eventually going to get caught up. And, you know, it's not that I feel like, well, gee, I was clairvoyant. It was just obvious from the level of heroin addiction that when you now allow a supply of methadone out into the community, followed by oxycodone and others, was that you're going to have trouble. I mean, it just isn't, it's not rocket science to figure that out. The problem is, how do you get back? How do you put the genie back in the bottle? And, you know, I don't see that it's going back in the bottle.
Actually, I do want to say in Multnomah County, in I think other parts of Oregon, I don't know about the rest of the country, there has been, I think, movement to correct this. Part of the fallout, however, is that we're getting more of these people who are less because now they don't have their supply of easy methadone or oxycontin, and they're coming to us for pain management. We think we have a better approach. We're still experimenting with it, actually, but I think there is a correction. The point is that when you make a correction, don't be so wild about it,
right,
and leave a bunch of people going through withdrawals who aren't ready to get in recovery looking for heroin. And I think that's the overcorrection that you want to be careful about. But you know, there's a lot of evidence that you were right about that. But I want to say there's good news here, but I see Gary's got his hand up, so I'll say something.
Well, Sam, thank you for being here. We kind of heard a little bit about some of the problems that we're in with addiction and some of the tools that are available that Rachel spoke of. But I think for me, as a person in long-term recovery, 14 years, I went through the Recovery Mentor Program. One of the tools that really highlights the success is that recovery support housing. And I'm kind of curious in your book tours and stuff, what you, if the conversation around housing has come up and that being such a valuable tool. I mean, there's another tool too that in the state of Oregon, the Good Samaritan law. So with the naloxone being available and if someone ODs, people can call the police and nobody will be arrested. Them are great tools that we have finally needed, but you know, that 75% success rate of the mentor program is due in part to people having that safe environment and having that group of people that are going through that same, experiencing that same issue. And could that be another book you could write, possibly? Or something, you know, I guess if you made this
more
book,
down on this one. You know, here's what I would say. As I travel the country, this is such a new problem that for so many areas that people are just groping, stumbling around. The problem really is so new, and it's hit so many areas that never dealt with this before. One area though that I talk about in my book that's far ahead of the curve and reminds me a lot of what's going on here, and I were talking about this at lunch today, is Portsmouth, Ohio. Portsmouth, Ohio is a Rust Belt town. It's a town that has gone through a horrible process of kind of deindustrialization, and my book is called Dreamland because they had for many years an enormous swimming pool the size of a football field. It was really like the central square and the plaza that kind of held life together, around which life revolved. We talked about this theme of community and connectedness. Rachel was mentioning a super important I think, in all this. Portsmouth, that pool was called Dreamland. That was the name of the pool. Beautiful pool. People have these glorious memories of it. They tore it up, and it's now a strip mall. In 1993, when the town was really kind of declining and all, Portsmouth went first, probably of any town in America, through this process that we've been talking about. It also seems to be the town that is leading, at least that part of the country, out of it. And they're trying a lot of the things that you see here at Central City. A combination of approaches, bringing it all into kind of a few buildings near each other, so you don't have to go get a referral to go across town to get one service and then across town again, you know, that kind of thing. It's all kind of close. It's offering jobs to a lot of recovering addicts in Portsmouth. I think that's what's done here as well. There's some housing component now that they've been able to build because there's so many abandoned buildings in Portsmouth. They've been able to expand out. It's now one of the largest employers in Portsmouth, Ohio. But you find what seems to me to be kind of a theme is that, and housing is crucial to it, and in that place and here too, it sounds like. But the idea of kind of building a community. That town, once it lost its steel mill, its shoe factories, and its swimming pool, disintegrated. Walmart took the place of the pool. Cops became the new parents, and everyone went indoors. And opiates made quick work of a town like that. Quick work. And now what seems to be very exciting is when you see those kinds of examples of a town kind of moving out of that, and the way it's doing it is rebuilding, in a sense, that community feel a little bit. It's got a long way to go. It's an ugly town. It's a beat down town. It looks like a junkie who's hit rock bottom. That's what that town looks like. And the town itself is kind of almost dead. It saved itself. This weird story, real quick, I'll tell you. It saved itself. They were going to close. There was all these shoe factories in Portsmouth. They also had the world's largest, or the country's largest shoelace manufacturer. They were about to, that was the last factory that vested from those days. And they were about to close it because, you know, the grandchildren of the founder were now running it, and they really just wanted to play golf all day, you know. So when bankruptcy, a few community people, local insurance salesman and a lawyer and a couple of folks like that, construction contractor, said, we can't do this anymore. We can't allow this. They kind of had accepted that all that manufacturing was just preordained by some University of Chicago economists to go to Malaysia or Mexico. And now they were saying, you know what, no more. This is okay. And they saved the plant. They saved the shoelace manufacturer. And it's now exporting shoelaces to China and Taiwan and Mexico, and it's employing 90 people. That gets to the larger question. I think the question you were asking, which is the importance of community building in all this. So for so long, I think one of the reasons we're suffering from this as a country is because so much of the country is kind of all turned in on itself. Even wealthy areas, particularly wealthy areas, I bet, you know, are kind of so, you would see kids on the street, you know, and in Portsmouth, that was, I wrote this book about this very downer topic, thinking the whole time, I gotta find some place that's looking up here. And Portsmouth was the place. It was really weird when I finally realized that was the story underneath the story that I'd been watching. That this is a town, 10% of the town's in recovery, okay? And they got a new shoelace factory now, and they have this kind of recovery culture, all of which is built around this counseling center that is using kind of like the same things that I think are being used here, which is this community idea, this multidisciplinary approach. We're not going to just use one way. There's a bunch of different ways, and there's employment help and all kinds of things like that. I guess that's how I answer your question.
So with that, just a couple of things. We have some staff around here, including myself. If you have any more questions, feel free to ask. Books. So if you have all these books back there signed by Sam. If you're a major donor, you can get a book for free. Our next event is coming up. The theme is going to be art in health. And if you come up the stairs here, you're seeing all this artwork. It's all over this campus. That was done by local artists. We recruited that art for the building. About $140,000 for the art. So our chief art and psychiatrist, our lead psychiatrist, is going to come talk about health and art. But I want to end this. That was hopeful, because I believe that people in recovery are part of this solution, a big part of it. I think communities are going to get turned around when there's a critical mass of recovered people in those communities, changing those communities. And working with others like Rachel and Leslie and our counselors here and our mentors, we're doing a good part of that work, but we're not the only ones. That's also good news. We work with a lot of partners in the community. But it's going to be that coming together that's going to turn this thing around. And we have great opportunity with the Affordable Care Act expanding Medicaid. That has created a whole new opportunity for people to get treatment. But I've never seen the healthcare world, from the largest hospitals to the executives at the very top, to certainly line workers in the healthcare systems, a greater awareness of the role of addictions that I've ever seen. I see it at the politicians, at the legislature in the county. So I think there's a growing kind of convergence of knowledge around the impact